Welcome back to another explainer. Today, we're diving into some truly fascinating, high-stakes clinical decision-making. We're going to explore exactly how we handle surgical nutrition, specifically.
Section 1, the surgical stress response. To really get this, we have to frame surgery for what it biologically is, a form of trauma. And in response to any trauma, the human body triggers this highly predictable, fiercely aggressive defense mechanism.
The exact second tissue is injured. Minute zero, a massive domino effect kicks off. Within just 1 hour, the brain triggers an intense neuroendocrine response, literally flooding the system with stress hormones. By 24 hours, an inflammatory response is in full swing, releasing cytokines that cause fever and mobilize the immune system. And as we push into that first week, usually around day 7, we enter a state called catabolism. Now, catabolism is a fancy medical term, but in plain English, it just means the body is violently breaking down its own tissues, especially muscle, to harvest energy and raw materials for repair. Now, this whole sequence basically splits into 2 distinct phases of recovery. First up is the ebb phase, right after the injury. Think of this as the shock phase. The body is just trying to survive and keep blood flowing to the vital organs. Cardiac output drops, metabolic rate slows way down, and body temperature actually falls. But once the patient is resuscitated and stabilized, they violently swing into the flow phase. This is the hypermetabolic phase. Suddenly, the heart is pumping incredibly hard, the body is demanding massive amounts of oxygen, and it starts breaking down muscle at a truly alarming rate. What's honestly mind-blowing here is how the body manipulates its own hormones to fuel this hypermetabolic flow phase. It aggressively ramps up stress hormones. We're talking catecholamines, cortisol, glucagon, and growth hormone, while also spiking hormones like ADH and aldosterone to hold on to water and salt. But at the exact same time, the body actively decreases the effect of insulin. The tissues literally become resistant to it. So you've got these massive stress hormones pushing sugar into the blood, paired with an active blockade on the insulin that would normally clear that sugar out. The result? Dangerous, stress-induced high blood sugar. And that leads us to a massive clinical trap. When you see high blood sugar in a surgical patient, you might think, oh, they just ate a huge meal. Nope. The body is actually producing brand new sugar entirely internally. It empties glycogen stores from the liver, and then it starts scavenging. It pulls lactate, it pulls glycerol from fat breakdown, and critically, it pulls amino acids to literally manufacture its own glucose. Let's walk through exactly why surgery causes such severe muscle wasting, step by step. Step 1. Surgery triggers those stress hormones we just looked at. Step 2. Those hormones dramatically increase proteolysis, which is just the breaking down of muscle protein. Step 3. This floods the bloodstream with amino acids. Step 4. The body aggressively uses those amino acids to create new sugar, build acute phase proteins in the liver, fuel the immune system, and heal the wound. Why this matters to you is simple. Major surgery causes a significant, rapid loss of lean body mass. The patient is literally consuming their own muscles to heal. Which brings us to a really crucial concept: negative nitrogen balance. Simply put, this is a state where protein breakdown is vastly greater than protein synthesis. The patient is losing way more than they're taking in. This severe depletion happens in surgery, trauma, burns, and sepsis. And there's a fundamental rule you've got to remember here. The greater the surgical stress, the greater this negative nitrogen balance becomes. Moving on to Section 2. Starvation versus surgical stress. It's incredibly easy to confuse the two, but biologically speaking, the trauma of surgery and the everyday process of simple starvation are entirely different beasts. The human body is actually remarkably clever when it's just deprived of food. In the first 24 hours of starvation, it uses up hepatic glycogen, that's sugar stored in the liver. Over the next few days, it has to use protein from muscle to make new sugar. But if that starvation is prolonged, the brain adapts. It stops demanding pure sugar and starts using ketone bodies derived from fat right around the 14-day mark. By doing this, the starving body fiercely protects its remaining muscle. It adapts to survive. And this brilliantly illustrates a classic exam trap, not to mention a critical medical reality. In starvation, the body adapts, reduces protein breakdown, and spares its muscle. But in surgical stress, that stress response continues unrelenting. The breakdown of muscle remains heavily increased regardless of what you do. Even if you feed a severely injured surgical patient, they remain highly catabolic. The trauma completely overrides the nutrition. Which perfectly sets up Section 3, assessing patient nutritional status.
Since we know surgery is going to ravage the body's reserves, how do doctors act as clinical detectives to assess a patient's exact nutritional status before they even hit the operating table?
Well, it all starts with a very simple number, 10. A 10% unintentional weight loss over 6 months is absolutely one of the biggest red flags for severe nutritional depletion. If a patient comes into the clinic and mentions they've accidentally dropped 10% of their body weight, the alarm bells should immediately start ringing.
Then comes the physical exam, right? Doctors are looking for visible clues of this depletion. They're checking for wasting in the temples or around the collarbones. They measure the tricep skin fold to check fat stores. They look for loss of fat in the cheeks. They're checking for edema, which is fluid swelling, or ascites, which is fluid in the abdomen. And critically, they're looking for severe muscle weakness. In fact, a loss of physical function, like a weakened hand grip strength, actually occurs long before any biochemical blood tests show abnormalities. Function always fails first. But you gotta watch out for what we'll call the BMI trap. A patient can be obese, meaning they have a high body mass index, and still be severely malnourished. They might have something called sarcopenic obesity, where they have excess fat but their muscle mass is entirely depleted. On top of that, edema or severe water retention can add a massive amount of weight to the scale. So excess body weight or fluid can dangerously overestimate a patient's true nutritional health. You really have to look past the scale.
All right, Section 4, key laboratory nutritional markers. Once the physical exam is done, we turn to the blood tests to track nutrition. But just like that BMI trap, we have to interpret these markers super carefully. When we track the half-lives of 3 major blood proteins, the differences are pretty striking. Now, a half-life is just how long it takes for half of the protein to degrade in the body. Albumin lasts a long time, about 20 days. Transferrin lasts about 8 days. But prealbumin, which is also known as transthyretin, has an incredibly short half-life of just 2.5 days. Because of this, prealbumin responds the fastest to nutritional changes. If you start feeding a patient today, prealbumin will absolutely be the first marker to show measurable improvement.
But here's a massive, high-yield takeaway about albumin. Yes, albumin levels fall when a patient is malnourished, but they also plummet during inflammation, sepsis, and liver disease. Why? Because during tissue injury, the liver stops making albumin and instead pumps out acute phase proteins like C-reactive protein, or CRP, to fight the inflammation. So, if a patient's albumin is low, but their CRP is high, the liver is just busy fighting an inflammatory battle. The low albumin in a surgical patient isn't just a simple lack of food. It's a marker of how sick they are. It's a prognostic marker, not a pure nutritional one.
Finally, Section 5, identifying high-risk patients. We know surgery causes extreme stress, and we know how to spot malnutrition. So who are actually the most vulnerable patients heading into the OR? Well, the list definitely includes cancer patients and the elderly, whose reserves are usually already pretty low. It includes those with chronic gastrointestinal or liver diseases, which prevent proper absorption of nutrients. Patients with severe pancreatitis, major trauma, burns, and sepsis are incredibly high risk because their bodies are already violently trapped in that hypermetabolic flow phase we talked about earlier. And honestly, anyone with prolonged vomiting, diarrhea, or high-output stomas and fistulas is simply losing nutrients way faster than they can replace them. So what do we do about all this? The ultimate solution really boils down to 3 steps. Step 1, identify the severe malnutrition using the clinical detective work we just covered. Step 2, correct that nutrition before major elective surgery whenever feasible. Why? Step 3, because a malnutrition patient has a massively increased risk of infection, anastomotic leaks, poor wound healing, longer hospital stays, and increased mortality. Catching the problem and optimizing nutrition before the scalpel ever even touches the skin is absolutely critical to saving lives. We've seen how incredible the golden principle. If the gut works, use it. Now, that sounds incredibly simple, right? But it is the absolute gold standard rule of clinical nutrition. Why? Well, because using the gastrointestinal tract does so much more than just absorb calories. It actively maintains the physical integrity of your intestinal mucosa. It preserves the gut-associated lymphoid tissue, which is a massive, absolutely crucial part of your immune system. By keeping the gut working, we significantly reduce what's called bacterial translocation. Basically, we stop gut bacteria from escaping through the intestine walls and leaking into the bloodstream. Plus, on top of all that, it's vastly cheaper and carries way fewer infectious complications than intravenous feeding. Section 2. Feeding through the gut.
So ideally, eating food normally, oral nutrition, is the preferred route. But when swallowing just isn't safe or the patient is way too ill, we pivot to enteral nutrition. That means delivering nutrients directly into the GI tract. We use this when a patient can't eat, maybe because they're on a ventilator or they have head and neck cancer or they just had major surgery, but their gut itself is actually still functional. And here's a really critical distinction to keep in mind. A functioning gut is not exactly the same thing as a functioning stomach. A patient might have a severely damaged stomach, but their intestines work perfectly fine. We can still use the gut, we just have to creatively bypass the stomach.
Now, what's really interesting here is how time literally dictates our strategy. If a patient only needs feeding support for a few days, maybe a few weeks, we go with a nasogastric or NG tube that goes right in through the nose and down into the stomach. It's relatively easy, no surgery required. But if we're looking at a long-term situation, months or even years, we shift gears to a PEG or a gastrostomy. That simply means creating a small direct opening through the skin of the belly directly into the stomach. The source data maps this out perfectly in a route selection matrix. Like we just said, short-term usually means an NG tube, and long-term means a PEG. But what if the patient has a high aspiration risk? That changes everything. If there's a high risk of food coming back up and getting into the lungs, we have to immediately push that feeding tube completely past the stomach's pyloric valve, down into the jejunum. That's a nasojejunal or NJ tube. Similarly, if the stomach simply can't be used at all, say after a major upper GI surgery, we bypass the whole thing and go straight into the intestines with a jejunostomy. So once we have that tube successfully in place, what exactly are we pumping through it? Well, we can actually chemically tailor the food based on how broken down the patient's digestive system is. Polymeric feeds are pretty much like a normal blended meal. They've got whole proteins and complex carbs, which is perfect if the patient's digestion is mostly normal. But if their digestion is impaired, we step down to oligomeric or semi-elemental feeds. Those are essentially pre-digested into smaller peptides. And for severe malabsorption, we use elemental feeds. These are nutrients completely broken down into free amino acids, requiring literally zero effort from the body to absorb. Okay, so we've seen how to adapt to a damaged gut. But what happens if the gut is completely obstructed? Or what if it's suffering from severe ischemia, meaning a dangerous lack of blood flow, or massive peritonitis? Our source data is super strict on this. If a patient is hemodynamically unstable, meaning they are in shock, you have to resuscitate them first. You absolutely do not aggressively feed a patient who is in uncontrolled shock. But once they are finally stable, if that gut is dead or blocked, we have no choice but to pivot. Which brings us to Section 3, feeding through the veins. This is our heavy-duty alternative, parenteral nutrition, often known as total parenteral nutrition, or TPN. Now keep in mind, this is never ever done just because a patient is temporarily fasting for a day or two. TPN provides complete, total nutrition intravenously, 100% bypassing the gastrointestinal tract. We only deploy this in severe critical cases. Think complete intestinal obstruction, short bowel syndrome, or a severe prolonged ileus, which is when the gut is basically paralyzed and completely stops moving. We really have two main ways to deliver TPN. Peripheral TPN is given through a standard vein in the arm. It's much easier to access and has lower risks, but it is severely limited. Those small arm veins just can't handle highly concentrated, syrupy, hyperosmolar fluids. Because of that, we can't deliver maximum calories, making it strictly a short-term fix. Central TPN, on the other hand, is the heavyweight champion. It's delivered right into a large central vein near the heart via a central line or a PICC line. It can handle complete hyperosmolar nutritional support for the long haul. But, as you'd expect, it comes with significantly higher risks. Breaking down exactly what goes into that central TPN bag is fascinating. It's a highly precise, individualized chemical cocktail. A massive portion of it is just carbohydrates, usually dextrose, acting as the primary energy source. Then you've got amino acids for tissue repair and muscle maintenance, lipids for essential fatty acids, and incredibly carefully calibrated doses of electrolytes, vitamins, trace elements like zinc and copper, and of course, water. We are quite literally doing the gut's entire job inside a sterile plastic bag. Section 4. Comparing the methods. When we put these two methods head-to-head, it becomes incredibly clear why the golden principle exists. With enteral feeding, that vital gut integrity is maintained. With parenteral, it deteriorates. Infection risks and financial costs are vastly lower when you feed through the gut. And while enteral feeding does carry some real risks, like pulmonary aspiration or diarrhea, TPN invites far scarier threats, namely severe bloodstream sepsis and incredibly complex metabolic issues. The data is absolutely clear on this. The vein is a lifesaver for sure, but the gut is always, always preferred. Let's look at a complex surgical scenario to see this logic in action, managing a high-output enterocutaneous fistula. Basically, this is an abnormal leaking connection between the bowel and the skin. Think of it like a dangerous plumbing leak in the body. Step 1 is always fluid replacement. Step 2, electrolyte correction. Step 3, sepsis control. Notice how nutritional support is all the way down at step 4? You absolutely must stabilize the fluids and fight the infection before you even worry about the calories. And then, depending on the exact anatomy of that leak, we might squeeze by with enteral feeding, or we might be completely forced to use TPN.
Section 5. Complications and traps. Now, even the preferred enteral route has its fair share of dangers. Mechanically, tubes can kink and get blocked. Pulmonary complications are a massive risk, specifically aspiration pneumonia, where feed gets into the lungs. Though a really simple, vital fix for this is literally just elevating the head of the patient's bed. Gastrointestinal complications include cramping and diarrhea. And metabolically, this is a big one. If you aggressively feed a severely malnourished patient too quickly, you risk triggering refeeding syndrome. That's a deadly, sudden shift in fluids and electrolytes when a starving body is all of a sudden flooded with calories.
And here is a classic clinical trap highlighted in the sources. A surgical patient is on an enteral feed, and suddenly they develop severe diarrhea. The immediate instinct is to blame the tube feed and just shut it off. Don't do that. Always pause and investigate first. The true culprit is very often antibiotic-associated diarrhea or a nasty C. difficile infection. The takeaway? Don't unnecessarily starve a recovering patient by blaming the wrong suspect.
Now, if enteral complications are tricky, TPN complications can be downright terrifying. The absolute most important risk to watch for is a catheter-related bloodstream infection. You have a plastic tube running highly nutritious sugar water directly into a vein near the heart. It is a literal magnet for bacteria. Metabolically, all that excess dextrose causes very common hyperglycemia. And hepatobiliary complications are huge if a patient is on it long-term. Because you're bypassing the normal digestive trigger of eating, the gallbladder just sits there doing nothing, which leads to gallbladder sludge, gallstones, and eventually liver dysfunction. Which leads us to another major clinical trap. You can never, ever, just suddenly pull down a TPN bag and stop it. Think about it. The patient's pancreas has been pumping out massive amounts of insulin just to deal with that continuous intravenous glucose. If you abruptly pull the plug on the dextrose, all that excess insulin is still circulating. It will completely crash the patient's blood sugar, causing severe, highly dangerous rebound hypoglycemia. You absolutely must slowly taper it off.
Okay, let's rapidly lock in the absolute must-know takeaways from today's data. Got a functional gut? Enteral. Non-functional? Parenteral. High aspiration risk? Bypass the stomach and go post-pyloric. Dealing with severe acute pancreatitis? Modern principles say enteral is actually still preferred whenever it's tolerated. And a severely malnourished patient starting feeds? Watch them like a hawk for refeeding syndrome.
Right. Let's kick things off with Section 1, Nutrition Basics and Calculations. Because, we really have to understand the baseline needs before we can treat a body in crisis.
Think about a general surgical patient. They usually need about 25 to 30 kilocalories of energy, and maybe 1.0 to 1.5 grams of protein per kilogram of body weight every single day. Pretty standard, right? But when someone suffers from severe burns, major trauma, or sepsis, everything changes. The body enters this massive catabolic state. It's basically breaking itself down just to survive, triggering an intense hypermetabolic response. The energy expenditure, the protein breakdown, the nitrogen loss, they absolutely skyrocket. All that normal math? Toss it right out the window. High-calorie, high-protein nutrition becomes an absolute necessity just to keep the walls of our fortress standing.
Moving right along to Section 2, Managing Critical Stress States.
Let's actually step onto the battlefield now and look at a specific scenario like fistulas. When a patient develops a high-output enterocutaneous fistula, which is where the bowel essentially leaks out to the skin, they are losing massive amounts of fluid. And with that fluid goes vital sodium, potassium, and magnesium. They're being rapidly depleted. To counterattack this, we use a strict step-by-step protocol called SNAP. S stands for sepsis control. N is nutritional support, meaning we meticulously replace those exact fluids and electrolytes to stave off malnutrition. A is for anatomy definition, and P is your plan or procedure. This sequential, step-by-step support is absolutely vital. Why? Because it can actually help the fistula close up all on its own, or at the very least, it gets the patient stable and safe if they end up needing surgery.
Now let's see how this builds during severe trauma or sepsis. The body kicks off this massive stress cascade. We're talking catecholamine release, a huge spike in cortisol, hypermetabolism, and even insulin resistance with high blood sugar. Because of this massive, overwhelming stress response, we have to stick to a rigid timeline. Step 1 is always sepsis control. Step 2 is hemodynamic stabilization. You absolutely must get the blood flow and vitals stable first. Only then do you move to step 3, early appropriate nutrition. Seriously, if you try to feed a hemodynamically unstable patient, their system just can't process it. You have to stabilize first, feed second. So when it finally is time to feed, we essentially have two main routes. There's enteral nutrition, which means feeding them right through the digestive tract, and parenteral nutrition, which is intravenous feeding, straight into the veins. Now, in severe crises like acute pancreatitis or severe burns, enteral nutrition is heavily, heavily preferred. You might be wondering why. Well, using the gut actually maintains the gut's physical integrity. It literally stops bacterial translocation. That's a fancy way of saying it prevents the bacteria living inside the gut from leaking out into the bloodstream and causing terrible infections. So we get this golden rule of clinical nutrition. If the gut works, use it.
Okay, let's shift gears to section 3, chronic illness and wasting.
We just covered acute, sudden trauma, right? But what about those slower, equally dangerous seizures where the body slowly begins eating itself over a prolonged period? In these drawn-out scenarios, we see sarcopenia. That's a profound loss of skeletal muscle mass, strength, and function, which drastically increases the risk of falls and post-op complications. But here's where it gets super interesting and honestly, pretty counterintuitive. It's a condition called sarcopenic obesity. A patient can actually have high body fat, but at the exact same time have dangerously low muscle mass. This means someone could have a completely normal or even high body mass index, but underneath it all, they are severely malnourished. A high BMI simply doesn't guarantee that a person is actually getting the nutrition they need.
And this brings us to a really vital distinction between simple starvation and cancer cachexia. See, simple starvation is just a lack of intake. You can usually reverse it just by giving the person food. But cancer cachexia? That involves weight loss, severe muscle wasting, weakness, and loss of appetite that is driven by an active internal fire. That fire is fueled by inflammatory cytokines, specifically things like TNF-alpha, IL-1, and IL-6. Because of this underlying, roaring inflammatory catabolism, just giving the patient nutritional supplements isn't going to completely reverse the cachexia. The body is actively breaking itself down, and calories alone just can't extinguish that kind of fire.
Let's move to section 4, micronutrients and wound healing. To rebuild its defenses, the fortress needs microscopic soldiers. Let's do a quick roll call. Vitamin C drives collagen synthesis. Without it, patients get scurvy, which means poor wound healing and bleeding gums. Then there's zinc, which powers DNA synthesis. A deficiency here means poor healing, dermatitis, and a weakened immune system. For blood and getting oxygen where it needs to go, iron is non-negotiable for hemoglobin. Missing it causes microcytic anemia. Now here's a classic comparison for you, vitamin B12 and folate. Deficiencies in either one will cause megaloblastic anemia, but B12 deficiency brings along neurological symptoms, whereas folate deficiency doesn't. And finally, vitamin D is your go-to soldier for bone health, while vitamin K is busy synthesizing your coagulation factors so your blood can actually clot.
Beyond those basic vitamins, we have immunonutrition, which brings some really specialized strategies into play to modify the immune and inflammatory response. We've got arginine, which is vital for nitric oxide synthesis and healing wounds. Glutamine acts as the absolute favorite fuel for enterocytes in the gut and for our immune cells. Omega-3 fatty acids jump in to help modulate inflammation, and nucleotides assist with all of this as well. But listen, the absolute most crucial takeaway here is that these fancy specialized components, they are completely useless if we don't first provide those basic adequate calories, protein, and appropriate surgical treatments we talked about back in section 1. All right, we've made it to our final part, section 5, crucial scenarios and traps. Let's lock in everything we just learned. So let's put on our detective hats and piece this all together. Scenario 1, you're evaluating an obese cancer patient. Now, despite their high body weight, they're showing severe muscle wasting and weakness. Based on what we just discovered about BMI and chronic illness, what exactly is happening here? The diagnosis is sarcopenic obesity combined with cancer cachexia. High body fat absolutely does not protect a person against the profound muscle loss caused by those inflammatory cytokines. Remember, obesity never excludes malnutrition. Okay, next scenario. A patient comes in with a complete intestinal obstruction. It's totally blocked up, and they are going to need prolonged nutritional support. Thinking back to our golden rule of feeding routes, Which route makes the most sense here? In this case, you have to use parenteral nutrition, intravenous feeding. Now, I know we said we always prefer enteral nutrition to protect the gut, but an obstruction forces our hand. The gut is literally blocked, making enteral feeding completely impossible. So we have to bypass the gut entirely to make sure the patient gets the fuel they desperately need.
All right, now for a truly critical scenario. Imagine a severely malnourished patient is finally started on nutritional feeding. But suddenly, instead of getting better, they develop profound weakness and a really dangerous cardiac arrhythmia. Why on earth did the very act of saving this starving patient trigger a deadly biological reaction?
Well, this is known as refeeding syndrome. When you reintroduce food to a starved body, it causes this massive, abrupt shift in fluids and electrolytes that can literally crash the heart. Before feeding a high-risk, malnourished patient, you always have to give them thiamine and correct their electrolytes. But what is the number one, single most characteristic electrolyte abnormality you are hunting for here?
It's hypophosphatemia, a super dangerous drop in phosphate levels. You have to anticipate this exact mineral crash to prevent refeeding syndrome and keep your patients safe when you're starting them back on nutrition.
At the end of the day,
exactly what we're dealing with here. Refeeding syndrome, or RFS, is a potentially fatal metabolic complication that happens when nutrition, especially carbohydrates, is reintroduced after a period of severe starvation. Think of it as a critical metabolic ambush. The body has deeply adapted to surviving on nothing, and the sudden reintroduction of food completely shocks the system.
Section 1. The starvation trap. To figure out why feeding can be so dangerous, we first have to understand what the body is actually doing during those long stretches without food. The core deception of starvation is brilliant, but it's deadly. During starvation, your body flips a switch and starts burning fat and protein instead of glucose. It's just doing whatever it takes to keep you alive. But behind the scenes, essential intracellular stores, the crucial elements packed inside your cells, like phosphate, potassium, and magnesium, are quietly becoming completely depleted. The trap here is that a patient's standard blood test might come back looking perfectly normal. The serum levels circulating in the blood seem fine, but the actual cells, they are dangerously empty warehouses just waiting to collapse. Section 2. The dangerous insulin surge. Let's track the chronological journey of what happens the absolute second a meal is finally given to those empty cells. Imagine those cells as empty warehouses that have been totally starved of inventory for weeks. Then, suddenly, at hour 0, a massive shipment of carbohydrates arrives. Within minutes, the body panics and releases this massive surge of insulin. Think of insulin as a frantic warehouse manager. Seeing all these new carbs, the manager desperately pulls all the available workers, which are our electrolytes, straight from the bloodstream and shoves them inside the warehouse to process the delivery. Over the next day or two, this frantic shifting completely empties out the bloodstream, leading to a severe, life-threatening crash. Here is exactly what that insulin manager is doing. The surge literally forces phosphate, potassium, and magnesium to violently shift out of the blood and into the cells. At the exact same time, processing those new carbohydrates requires a massive amount of a vitamin called thiamine, instantly burning through whatever tiny reserves the starved patient has left. On top of the whole shebang, insulin tells the kidneys to hold onto sodium and water. So now you're left with blood that is completely stripped of vital electrolytes while simultaneously swelling up with retained fluid. It is a perfect storm. So the crucial point is this. The major clinical consequence of this crash is something called severe hypophosphatemia. It's a mouthful, but it simply means dangerously low phosphate levels in the blood. In the medical world, this is the absolute classic hallmark of refeeding syndrome. Why is low phosphate so terrifying? Well, phosphate is the fundamental building block for ATP, the actual energy currency of your cells. It's also vital for a compound called 2,3-DPG, which is the mechanism that helps your red blood cells unload oxygen to your tissues. So without phosphate, you are literally starving your cells of both energy and oxygen. This leads directly to profound muscle weakness, which can actually cause the patient to just stop breathing, entering respiratory failure. It triggers cardiac dysfunction, erratic heart arrhythmias, and severe neurological issues like confusion and seizures. Section 3. Recognizing high-risk patients. We absolutely have to identify who is in danger before we feed them. And it's super important to note that this affects a huge range of patients, not just those with extreme conditions like anorexia. Now, what's really interesting here is how doctors calculate this risk step by step using the NICE guidelines. It's essentially a checklist. A patient is considered high risk if they meet just one major criteria. That means a BMI under 16, severe weight loss of over 15% in the last 3 to 6 months, absolutely no nutritional intake for more than 10 days, or low baseline levels of potassium, phosphate, or magnesium. But they're also high risk if they meet 2 or more minor criteria. This includes a BMI under 18.5, weight loss over 10%, little to no food for over 5 days, or a history of drug and alcohol abuse. So think about it. An elderly patient who hasn't been eating, someone struggling with chronic alcoholism, or even an obese patient who recently lost a massive amount of weight. They could all be walking right into this trap. Okay, here is a classic medical exam trap and an easy real-world clinical mistake. A normal phosphate level before feeding does not exclude refeeding risk. Remember our deceptive warehouse from earlier? The blood levels might look totally fine on paper, but those intracellular stores could still be running completely on empty.
Section 4, Step-by-Step Treatment Protocol. How do medical professionals actually navigate this minefield? We know the patient desperately needs food, but we also know the food can kill them. Let's look at how this builds. Doctors follow a highly rigid protocol. Step 1, identify the risk before a single bite is given. Step 2, administer thiamine immediately. Step 3, start nutrition incredibly slowly. Step 4, proactively replace missing electrolytes. And Step 5, monitor the patient's clinical status daily. These steps absolutely must happen in this precise, calculated order.
Step 2 really deserves its own spotlight. You have to give 200 to 300 milligrams of thiamine daily immediately before feeding begins. Why? Because thiamine is a non-negotiable prerequisite for carbohydrate metabolism. Without it, the body just can't process the new energy safely, which leads to severe brain complications like Wernicke encephalopathy. Thiamine is literally the key that unlocks the metabolic engine safely.
Once thiamine is on board, the caloric intake has to be aggressively restricted to prevent that fatal insulin surge. For high-risk patients, doctors limit the starting food to a maximum of just 10 kilocalories per kilogram per day. And for extreme risk patients, say someone with a BMI under 14, it is slashed down to just 5 kilograms per kilogram. To put that into perspective, that is a staggeringly small amount of food. 4 to 7, that is the number of days it should take to gradually, cautiously build a high-risk patient back up to their full normal nutritional requirements. You don't just hand them a full meal on day 2. It is a slow, methodical climb over nearly a week to make sure their cells adapt without crashing. Throughout this entire multi-day climb, the clinical monitoring is just exhaustive. Doctors are tracking phosphate, potassium, and magnesium daily. They're watching blood glucose, sodium, and daily weight for any signs of fluid overload or edema. For extreme cases, the patient is hooked up to a continuous cardiac monitor. And the coolest part? If electrolytes start dropping during this feeding window, doctors will just simultaneously replace them via IV or oral supplements, without necessarily having to stop the life-saving nutrition. Section 5, Common Traps and Takeaways. Let's pull everything we've learned together and bust a few persistent medical myths. Getting this wrong is the difference between life and death. The most dangerous trap is our own human instinct. You see a starving person and you naturally want to immediately give them a massive meal or glucose infusion to help them. But the clinical reality requires fighting that instinct entirely. You have to give thiamine first and introduce calories so cautiously. And remember, starvation doesn't just mean a person looks underweight. Even an overweight patient who just experienced recent severe weight loss is at a huge risk here. Let's do a rapid-fire summary to lock this in. The trigger sequence: feed a starved patient, their insulin naturally spikes, and electrolytes rapidly shift into the cells. The absolute hallmark abnormality to remember is hypophosphatemia. The key preventative measure is giving thiamine before feeding. Starting calories are brutally low, just 5 to 10 kilocalories per kilogram per day. And if things go wrong, the major complications include fatal arrhythmias and respiratory failure. Which brings us to a really fascinating final thought. If the body's own brilliant survival mechanisms during starvation can actually make the ultimate cure deadly, how else might we be completely misunderstanding the human body's hidden adaptations? It really makes you appreciate the delicate, fragile balance of our own biology, doesn't it? Thanks so much for joining me for this explainer today. Keep questioning and keep learning.